Okay, thank you so much, sir, for the kind introduction. And this is a keynote address. So basically, it is not part of the instruction course, but I would say that good capsulex is the initial step for achieving emetropia. So maybe that can be considered in that way. So I'm Dr. Sourabh Patwardhan, and my interest is in teaching, and I try to devise techniques to teach my students and fellows. So in this talk, I'll be speaking about the physics, the knowledge of physics, how it helps in doing a good capsulorhexis. So the first important thing which we have to look at is the intraocular pressure, because once we open the anterior capsule, we must understand that cornea is open, and now the anterior capsule is open. Then the intraocular pressure, if it is high, it is going to cause extension of the capsulorhexis. Now these are few conditions where intraocular pressure is high, but few things which might be missed when we are doing the surgeries, like tight speculum, tight orbits, and also the raised intraorbital pressure because of peribulbar block. Many times we give peribulbar block and take the patient immediately for surgery, and we miss out on these points where the intraorbital pressure leads to intraocular pressure. And even if we are going with a good capsulorhexis, sometimes it just starts running out because the intraorbital pressure is high because of the preoperative peribulbar anesthesia. Another thing which we must notice, that every patient's eye is different, and that difference is mainly because of the scleral and zonular elasticity, which is variable. So elastic sclera is commonly seen in young eyes, like pediatric eyes or young adults, also high myopes, and these behave differently. So in these eyes, what is different is that not just the shallowing of AC, which is seen commonly causing the capsulorhexis extension, but even the increased deepening or excessive deepening of the anterior chamber can also lead to capsulorhexis problem. I will show you a very interesting video about this. So just watch here. The capsulorhexis is going fine, and the surgeon just inflated the anterior chamber too much with HPMC, and just the capsulorhexis just went out. Many times this is not seen because the pupil is not well dilated, but you might experience this in your surgery where you feel that you have done nothing wrong, but it was an excessive deepening of the anterior chamber which might cause capsulorhexis extension. So I think this is a new thing you must understand when you are doing. So anything in excess is not good during cataract surgery. We have to maintain the anterior chamber in its normal anatomical position as far as possible. And this happens because of the overinflation of the anterior chamber in eyes with elastic sclera. So in this situation, what should we do? We should rather use heavy dispersive OVD rather than using HPMC to inflate, because what the HPMC does is that it inflates the anterior chamber rather than putting the weight over the anterior capsule. So rather use a heavy OVD which puts the weight on the anterior capsule without extension or expansion of the anterior chamber. Another thing, it's important to understand the anatomy of the anterior capsule. So if you see, normally the 6.5 millimeter and beyond is the area of zonule. So your capsulorhexis should be within the 6 millimeter area. And in some cases, there might be long anterior zonules, which you have to observe during the surgery. So always make sure that this capsulorhexis never extends beyond the 6 millimeter area. So the aim should be 5.5 millimeter, because once you go beyond, like for example, this particular trainee was doing capsulorhexis, he felt that he was going fine, but if you see the actual anatomy and actual size, he was way beyond the 5.5 millimeter mark, and now it was going into the zonular area. And zonules, what they do is that they pull this capsulorhexis margin outwards. So obviously a good going rhexis suddenly went into zonules. I'm sure that many young surgeons have faced this, and they feel that everything was going fine. Why this happened? Another thing which you may notice in some cases is that the anterior capsular surface is very convex, and that leads to more outward force. So in such cases, if you go beyond 5.5, you will find that there is significant outward movement of the capsulorhexis tear. It happens obviously in intumescent cataract, but also happens in small eyes. So when you see a convex surface, just wanted to show this particular test which I use for intumescent cataract. I call it viscopress test. So what is viscopress test? Once you, I'm sorry. So once you put the OVD, how to, okay, pause it. Okay. So once you press the, I'm sorry, I want to show you this. Okay, once you put the OVD in the anterior chamber, just look. In 3D, you can appreciate it better, whether the anterior capsule is flat or not. If anterior capsule is flat, then what happens is that there is no outward force on the capsulorhexis margin, and then you can have very easy capsulorhexis. you can just remove the intralenticular pressure and you can go ahead. But even after putting OVD, if you find that the anterior capsule is too convex, in such cases you have to be more careful. That indicates that the intralenticular pressure is really high, and these are the real intumescent cataracts. So just remember this visco press test when you go ahead in your OT next time. Another thing, how to take this extending capsulorhexis inside. So it's important to understand the vectoral forces here. So this is the area of zonules. As I already told, that zonules are going to pull this capsulorhexis tear outward. Okay, this is the force which the zonules are going to apply. So in order to negate this force, you have to either do completely opposite way, that is pull it centrally, or the Little's maneuver way, that is pull it unfold the flap and pull it other way. But what happens commonly is that you tend to, one second. So what happens commonly is that instead of pulling it centrally, you tend to pull it tangentially, as is your natural, the pull, the tangential pull, and it leads to further extension because the resultant force is outward, it's not inward. Same thing, excess OVD injection, I already showed it. And the second thing, important thing, is the pull has to be quick. Most have often, what happens is that you are hesitant to pull the capsulorhexis in. When you pull slowly, in fact, the vectoral force is still going outside, and that's why when you pull slowly, it still goes out. And I will just show in one of the videos. So you have to make sure that a resultant vector is not outward, but it should be completely inward. Okay, so let me just show this video. Just watch this. Capsulorhexis already into zonules, and now when I pull it slowly, it still goes out. But when I pull it with quick maneuver, it comes in. So the vectoral forces are being changed here by quick pull centrally. So this is very important. Most problematic thing is that you are hesitant to pull it quickly and centrally. So make sure next time if it is going into zonules, here the pupil is well dilated. Still, you can see from the zonular area, I can just pull it in even when the the zonules are still attached to the capsulorhexis tear. This is a very important trick to have, and with this trick, you will not never have extended capsulorhexis, because you can pull it back even from the zonular area. So understanding physics makes you understand the response of ocular tissue, which is very important when you are doing surgery. So thank you so much. Hope I was quick. I wanted to make sure that you get enough time for the instruction course. Thank you so much.
Thank you so much. It's a very excellent presentation. I think the things what we do won't understand also, but how it works that make us to make our surgery better if we understand the basics of these things. Thank you.